My name is Mark Wagner, and for the next 20, 30 minutes, we're going to be talking about stem cell treatment, what we treat, what it is, how it works, who's a good candidate, who's not a good candidate. Um, a little background on me. I've been around here actually about 35, 40 years in Seattle, founder of Seattle Sports and Regenerative Medicine, senior partner medical director at the Sports Medicine Clinic and University of Washington Medical Center, consulting team physician to the Mariners, fellow of the American Academy, and diplomat of the American Board of Family Practice. So, first, we're going to talk about the different conditions that we treat with stem cells. Um, I'll start in the bottom left corner and then rotate around. And then I'm just going to kind of mention these very briefly now, and then we're going to go into each one as we extend onto the next slide. Synovitis, inflammation in a joint, can be any joint. Osteochondral defects are kind of like osteoarthritis light. In other words, it's a focal area of damage to the cartilage. Osteoarthritis basically can be any joint, and that's more widespread damage to the Teflon covering of the joint. Tears in the meniscus, labrum tears. Labrum tears are like meniscus, like, we all have heard about meniscus tears, but the labrum is like the meniscus of the shoulder and of the hip. Partial ACL tears, rotator cuff tears, chondromalacia is damage to the Teflon covering of the joint before it actually extends down to involve the bone, which by definition would then be osteoarthritis. And then tendon injuries like tendonitis, tears of the tendon, complete tears, partial tears, and what we do to treat those. So, osteoarthritis. This is actually an x-ray from 10 years ago of a 40, or I think she was 48-year-old female with severe osteoarthritis of her knees that at her tender young age did not want a knee replacement. So we performed stem cell therapy treatments on her. She came back to see me because she wanted to treat her shoulder about a month or two ago. And I asked her how her knees were doing. She said they're doing great. She's not running marathons, but she's able to do all the activities that she wants to do and was able to put off a total knee replacement, which at age 48, she's very, very young to have a total knee. Um, so some of these slides, actually, I was talking to the American College of Foot and Ankle Surgeons a couple months ago. Some of these are from there, but basically, we treat osteoarthritis in many different joints, most commonly knees, hips, and shoulders, but also ankles, mid-feet. So this is a mid-foot osteoarthritis between what two bones called the talus and the navicular. And these are osteochondral defects. So osteochondral defects, or OCDs, are areas of the cartilage and the bone that for some reason get damaged and they lose blood supply. And it's almost as if it's like a crater through the cartilage that goes down to the bone. Very common in ankles and in knees. We treat these do phenomenally well with stem cells. And a lot of times we see them in young people as a result of, an ankle sprain, a knee sprain, or an old injury. Meniscus tears. Meniscus tears, very common. Actually, there was just a study that I've got on my desk here that I got about a week ago that the study, what's the title? Title of the study is that knee surgery for cartilage damage does not benefit patients. We've kind of known this for a while, but this is a study that came out of a researcher and orthopedic surgeon at the University of Helsinki. And basically, they suggest that arthroscopy for meniscus tears is what is known as a medical reversal. In other words, broadly used therapy proves ineffective, and even harmful. They took 146 patients from age 35 to 65 from 5 Finnish hospitals. The patients were randomly assigned to either have meniscus surgery or a sham surgery. In other words, where an incision was made, but no operation was carried out. After 10 years of follow-up, the group that received the meniscus surgery had poorer knee function and greater progression of osteoarthritis and a higher likelihood of subsequent knee surgery. So we've kind of known this for a long time. You go in and you mess with the meniscus, take it out. There's a reason that we have the meniscus in the knee, and it's to provide support and stabilization and cushioning for the knee joint. So we like to leave the meniscus there and heal it in place. The meniscus does not have a blood supply, so it's never going to heal on its own. So some people, they think the meniscus was repaired, that the surgeon put sutures in it, but they're never going to heal unless they're way out on that outer periphery of the meniscus where there is a little bit of a blood supply. Those are fairly rare tears. But we can heal meniscus tears with stem cells and actually work very well. Labrum tears. So the labrum is basically the meniscus of the shoulder and the hip joint, but it's a little bit different morphologically. In other words, it's like a gasket, kind of like a ring of Saturn per se. And those get tears in them all the time. We treat them, once again, we treat them with stem cells because surgery for hip labrum tears, not a great option, especially if you're over the age of 40, because that joint is very tough to get into. And you have to put about 100 pounds of traction on that leg in order to get the joint opened up enough to get a scope in there. So most surgeons, they do not want to do surgery for labrum tears. And they'll tell patients, just wait until your hip is so bad and we'll do a total hip replacement. Partial ACL tears. This is where the anterior cruciate ligament in the knee is still intact, but there is some degenerative tearing or an acute tearing, but it does not go throughout the entire tendon. As long as, or in other words, the ligament, not tendon, as long as there's still tendon or ligament intact, or in other words, I look at it as like if there's still a blueprint there, these patients do very well with stem cells and you can completely heal your ACL tear. Now, Grant, I have treated 4 now complete ACL tears with stem cells, and all of them have gone on to complete healing. However, I don't recommend that. I've done these. One was a silver medalist from Norway. She's a Nordic skier. She refused to have surgery and had stem cells and had complete healing of her ACL. The other 2 patients were female. They're all women. MMA fighters who tore their ACLs and refused to have surgery. And there we treated them with stem cells. They both did great. One of them came back because she tore the ACL in her other knee, and we treated it conservatively with stem cells, and she's doing fine. But I still, for complete ACL tears, I'm still recommending surgery, unless for some reason the patient absolutely does not want a surgery or is not a candidate for the surgery. This is an ACL tear. You can see the ligament should be a nice black structure that runs right through the middle. Here you can see it's completely torn. Rotator cuff tears. So if somebody has a bad fall, bad injury, and they completely tear the rotator cuff and they can't lift the arm up past about 30 or 40 degrees, they need surgery. If somebody, however, has a chronic tear that's been that way for a while, most of the time you can't do surgery to repair the cuff because the tendon shrinks up and comes apart and you can't get them back together. So in those cases, stem cells aren't going to get them back together either, but oftentimes they relieve the pain and improve function because there's 4 rotator cuff tendons, and typically there's maybe 1 or 2 that become torn. Now, where stem cells work very, very well is in partial rotator cuff tears. Partial cuff tears always tear in a place called the critical or the avascular zone. It's an area of the tendon that has a really poor blood supply. So if you do surgery for those, you put a bunch of sutures in there, you compromise the blood supply even more. And we know that 60 to 90% of those surgeries will fail within 5 years, giving stem cells, making them a much better option for treatment. Chondromalacia, this is most typically kind of behind the kneecap, but it can happen anywhere. It's damage to that Teflon covering of the joint, the articular cartilage, but it hasn't gone deep enough yet to start to affect the bone. Very common in women runners. We treat lots of this. Sometimes patients can get by with just PRP, which we're going to talk about later. Sometimes they don't need stem cells. Sometimes they do. It depends how bad the chondromalacia is, and it depends on exam on the patient. Tendon injuries. We treat a lot of Achilles tendon tears, partial tears. Once again, I do not treat complete tears because they pull apart and you got to get them back together surgically. And also partial patellar tendon injuries. We treat tendon injuries at the elbow, like tennis elbow and golfer's elbow, tendon injuries at the wrist, at the thumb, and then the tendons on the sides of the ankles, which are the posterior tib tendons and the peroneal tendons. Yeah, this was basically a near complete Achilles tendon tear. You can see here's the muscle up top, and then we kind of lose the distinctness of the Achilles tendon until we get way down here at the bottom. You can see the black structure, but it is still intact, and I can tell that on exam, not necessarily by this patient's study. This is a guy who we did stem cells on. He did not want to do surgery. He's a big tennis player and golfer, and he had stem cells on 7 other joints and has done phenomenal. He's like the poster child for stem cell therapy, and he's doing great. He's back tennis and golf and doing well. Synovitis just means an angry joint. It's basically an inflamed joint. If we see that and we get images and we don't see any damage to the meniscus, the cartilage, the muscle or tendon, I usually treat these, if they don't get better with anti-inflammatories and physical therapy, we'll treat them with PRP, which is just platelet-rich plasma, which decreases inflammation because we're really not trying to regenerate any tissue in these joints. All right, so we'll back up a little bit. So what is regenerative medicine? It is the field of study that utilizes stem cells to heal and regenerate damaged tissue. It's the use of autologous, meaning from your own body, adult mesenchymal stem cells to regenerate bone, cartilage, muscle, and tendon. We only want that one particular stem cell because it can grow up to be those 4 things, and it knows what to do. We can't program them. Elon will figure it out someday, but we can't program them. They're unspecialized cells that have the ability to renew themselves and transform into other cell types. This is a little video.
What is stem cell therapy?
That lasts about 4 or 5 minutes.
It's an injection treatment designed to heal injuries and reduce pain. It is used for arthritis and injuries to ligaments, tendon, muscles, cartilage, and bone. First, let's look at the difference between human embryonic stem cells and adult stem cells. The embryonic stem cells are fully formed, meaning that they can become any of the more than 200 million differentiated cell types of the human body. On the other hand, adult stem cells are multi-type, meaning that they can develop into more than one cell type that are more limited and controlled, and thus safer than pluripotent cells. We perform the adult stem cell treatment. What is the role of these stem cells? To understand this better, let's look at this example. Your house is exposed to different elements, such as wind, fire, rain, sun, and all cause damage to the structure. To keep your house in order and repair any damage, you need different professionals like firefighters, construction workers, insurance agents, and the contractors to supervise and direct the project. This is no different than your personal life. You need a dentist, lawyer, financial advisor, doctors, insurance agent, and a barber, along with other professionals. So, both your house and your life require different professionals and specialists to keep them working well. And your body needs stem cells. Now, let's dive deeper and see what happens to your joints. In a normal healthy joint, you have plenty of stem cells. These cells are not only capable of doing maintenance and repairs, they also know when and where these repairs are needed. The stem cells work with a contract that, in addition to giving instruction for repairs and maintenance, transform to specialized cells to do whatever is needed to fix any problem. When you have enough of these stem cells, there's a balance between damage and repair. You have no pain and no injuries. Think about when you were 18 years old. You were able to run, jump, and do the same the next day without pain. The only problem is that with time, the number of these stem cells goes down, or sometimes the severity of the injury or damage is more than ability your body to repair it. This leads to an imbalance, and ultimately to arthritis, injuries, and pain. In essence, as you age, you have a lower number of contractors and workers available to do the job. Or sometimes the amount of damage is too much for the available stem cells. But fortunately, there are areas of the body that keep a good number of stem cells. These areas include the bone on the hips, fat, and abdomen and buttocks. And this is the key to stem cell therapy. The doctor will take stem cells from one or both of these areas and transfer them to the area of injury or arthritis. This will provide the stem cells needed for repair. In essence, the treatment will supply the manpower needed to do the job. Once there, these cells secrete growth factors that will organize and coordinate other cells to do the repairs. This leads to healing. This is like the contractor giving instructions to get the job done. This treatment can be used for pain with injuries coming from ligaments, tendons, muscles, bones, cartilage, and meniscus. When is it useful? If you have an injury or an arthritic condition that does not improve with therapy, medication, other injections, or surgery, or if you were told you need surgery, then stem cells is a great option for you. Thanks for watching.
Okay, so hopefully that helped. I love that little video. I think it gives a lot of good information. So when we were 10 years old, there were like 200 million stem cells circulating around in your bloodstream, as opposed to maybe 2 million when you get to be 60. So the numbers do decline with age. However, there's still these localized pockets, areas where there's very high concentrations of stem cells, being your bones. And the posterior superior iliac crest, which is basically on either side of your spine, is where we get our stem cells. It's very easy to access. It takes me less than a minute to do a bone marrow aspiration. The stem cells not only have regenerative properties, but they have anti-inflammatory properties. They stop the arthritis, they stop the breakdown, and the inflammatory changes within the joint. So what we're trying to avoid is total joint replacement. And I'm just going to pick total knees because total knees do the worst of any joints. The hips do the best. Shoulders, so-so. But the big data on total knee replacements, 65 to 70% of patients who have total knees are happy with the results. But that means 30 to 35% are not so happy. And they can have increased pain after the procedure. The problem is that it's an end game. There's nothing else you can do at that point. I probably see 3 or 4 patients a month who come to me because they had a total joint a year or 2 or 5 ago, and they're miserable and they want me to do stem cells. And I said, well, nothing I can do because all you got in there is metal and plastic, and there's nothing we can do with stem cells. So, and then there's the complications of total knee replacement. Number 1, infection. Number 2, blood clots in the calves that can go and progress to number 3, which is a pulmonary embolism that can be life-threatening. Heart attack and stroke. There have been studies out that say that men and women over the age of 60 have a 30 times for men and 25 times greater for women incidence of heart attack and stroke in the 1 year following a total knee replacement. Loosening, they don't last forever. Depending upon your activity and your weight, you could be looking at anywhere between 8 and 15 years. There are some studies out that suggest that with any joint replacement, there might be issues with dementia from metallosis. Metallosis is from chromium, cobalt, nickel, and titanium, which leach into your bloodstream, make their way to your brain. All of these complications are increased if your body mass index is over 30. So there are a lot of people that are overweight, and they're like, they come to see me because they're miserable, and nobody will do surgery on them because they're too heavy, and they think they're sunk. There's nothing they can do. They can't exercise. They can't walk because it hurts so much. They can't lose weight. And so I get a lot of referrals actually from orthopedic surgeons who say, go see Wagner and have stem cells because you're not a good candidate for total knee replacement. Maybe you've got heart disease, diabetes, you got some other issues going on as well. So same thing with ankle. I mean, there are ankle replacements. Not everybody's a candidate for ankle replacement, especially those people who have peripheral vascular disease, diabetes, if their bones are soft, if they have osteoporosis. Same thing for total knee replacement and total shoulder replacement. If you have osteopenia or osteoporosis, there's a good chance that those prosthetics don't seat well. Peripheral neuropathy. So once again, a lot of complications with those. Not a lot of people are good candidates for ankle arthroplasty, and then their only other option surgically is a fusion in the ankle, which is not a great option. So what do we do before the procedure? We avoid, well, a couple days before, NSAIDs, ibuprofen, Advil, Aleve, Relafin, meloxicam, turmeric, CBD. We have patients hydrate really well so that it makes it easy to draw their blood for the PRP. We always look at the medications they're on, because if they're on blood thinners, then sometimes we need to have them go off for a day or two, or we need to do something called a Lovenox bridge. Most of the time not, because we really don't see much bleeding with this procedure at all. The procedure itself takes about an hour. It's local anesthetic. It's done in our 2 procedure rooms in the office. First, we draw blood, and then utilizing a computer-run centrifuge, we're able to isolate platelets. Platelets are these great little packages of growth factors, cytokines, exosomes, and ultimately are like fertilizer for stem cells. When used by themselves, they're great anti-inflammatories. So we use them for tendonitis all the time. Then we do bone marrow extraction, which everybody's always concerned about because they think it's a disaster, it's going to be extremely painful. The bone marrow aspirate, I've done over 20,000 of these, and it takes me less than a minute to do a bone marrow aspiration. Half the patients are like, are you kidding? You're done already? And half are like, oh my gosh, that's a deep, hollow, weird sensation, or it feels like sciatic nerve pain going down my leg. If you're in that half, it's going to last about 30 seconds. And once that extraction needle is out, the pain is gone. Then we do a mini liposuction kind of right in the love handles area, because we get stem cells from bone marrow and stem cells from fat. By virtue of a very complex software program that runs our centrifuge, we're able to isolate just adult mesenchymal stem cells. Those are the only ones we want, and we're getting them in billions. Then we utilize ultrasound to guide the injections to either the tendon, the joint, the meniscus, the cartilage, wherever we're treating. Whole process, local anesthetic, in the office, you walk out, you do need a ride, and we start physical therapy, usually a week or so after the procedure. So blood thinners, we talk about if somebody's undergoing active treatment for cancer, if they've got metastasis or anything like that, We need to talk to the oncologist before we proceed on with anything. And certainly if somebody's got an infection, they have some type of sepsis or pneumonia or sinusitis or a skin infection, then we'll put off that procedure and just treat the patient with antibiotics. There are, unfortunately, a lot of providers, chiropractors and naturopaths who provide stem cell treatment. They hire nurse practitioners to do the injections because they're not allowed to by their licensure. They buy stem cells online. You can go on the internet and buy stem cells. They come from mostly women who are willing to sell their placentas south of the border. It's somewhat of a sketchy patient population, and there are no live stem cells in that product. It's a powder that they just reconstitute with sterile saline, and then the nurse practitioners inject it into whatever joint. I have seen some real disasters that have come from these clinics that do this, mostly infections, and then secondarily just patients who don't necessarily see any relief at all of their pain or their function. So patients with mild to moderate or moderately severe osteoarthritis, big data says 85% of patients obtain at least 80% improvement. In my patient population, we're at 91%. The nice thing about stem cells, there's no downside. Nobody gets worse. There's always a risk, yes, if you do an injection in any joint, there's a risk of infection, although, knock on wood, I've injected literally hundreds of thousands of joints without ever seeing an infection. So worst case scenario with stem cells, you fall into that 9 to 15% and you say, doggone it, it didn't help that much. Just going to run through briefly just some conclusions from some scientific journals and clinical studies. Actually, some of these are from this talk I did to the American College of Foot and Ankle Surgeons. So I'm going to go through those quickly and get, once again, this is an osteochondral lesion, which we talked about earlier, an OCD in the ankle, which was treated with stem cells and did incredibly well. Once again, here you can see the square bone in the middle of the ankle joint. You can see there's this dark area here. That's an osteochondral defect. Here it is blown up. This healed pretty much completely by 6 months with stem cells. So here, from the Journal of Bone and Joint Surgery, there was evidence of meniscus regeneration and improvement in knee pain following treatment with human mesenchymal stem cells. These results support the study of human mesenchymal stem cells for apparent knee tissue regeneration and protective effects. From the Journal of Clinical Orthopedics and Trauma, the versatility of stem cells as a treatment modality has landed at another repair target, osteoarthritis. Through many studies, this newly discovered method has been shown to significantly alleviate the pain experienced by osteoarthritic patients. From Helion, which is a European orthopedic journal, the study showed that a single intra-articular injection of bone marrow stem cells appears to provide long-term benefits. The procedure is simple, fast, well-tolerated, avoids the need for hospitalization, and generated no complications or adverse effects. From the Journal of Orthopedic Translation, in contrast to traditional treatments based on drugs, proteins, or antibodies, stem cells are poised to revolutionize medicine as they possess the capacity to replace and repair tissues and organs such as osteoarthritic joints. From Nature, which is basically the British New England Journal of Medicine, in conclusion, mesenchymal stem cell treatment improves knee pain, physical function, and cartilage quality without any severe adverse events. From Mesenchymal Stem Cells and Regenerative Medicine, cartilage mapping by MRI showed evidence of improvement in good cartilage quality and a significant decrease in poor cartilage quality. Journal of Clinical Orthopedics, the versatility of stem cells as a treatment modality has landed at another repair target, osteoarthritis. Through many studies, this newly discovered method has been shown to significantly alleviate the pain experienced by osteoarthritis in patients. These are some other studies that we don't need to go through. This was a big one out of NIH about 4 or 5 years ago that, basically says that the duration of efficacy out 2 years from a single treatment greatly exceeds that of any other treatment or possible placebo effect. There've been, now we're looking at over 65 million cases done in the US. As long as you use your own cells, which is the only way that I do it, there have been zero adverse effects reported on the FDA database. No general anesthesia. It's an hour procedure. You walk out, you start physical therapy a week later. Patients are pretty much doing all their activities of daily living right from the get-go. Most people go back to work the next day, unless you're working construction or something like that. We ice immediately after, just while the patient's in the procedure room. But after that, no ice for the first 6 weeks. We start physical therapy. We avoid non-steroidal anti-inflammatories. Most people get back to, spinning, if we're talking about knees and hips and ankles, spinning on a stationary bike by the second or third week, then onto an elliptical, and then just progressing. Most people start to see improvement in the 6 to 12 week range. Improvement, however, goes out to about a year and then tends to level off. Some data out of Japan says 2 years. That's pretty much kind of the basics on stem cells. And now what I like to do is open it up to everybody's questions. And then usually we kind of get into it, a lot more once we start answering those. So I think Chelsea's going to read me these questions and then we'll go through them.
All right, so this first person says, my fiance's mom is having this done on her knee somewhere in Seattle. Is it common in other places that you are totally limited to what you eat before the procedure? They have her almost starving. No bread, obviously no non-pasteurized dairy.
That's a little crazy. Yeah, no, because those stem cells, they need nutrition. They need to get calories. They need protein. So even if we have people who are obese, they say, well, should I go on a diet? I said, well, let's wait a little bit of time. We don't want you going on a crash diet, because those cells need nutrition. We tell people stay on their regular diets. So I would look carefully into that.
Someone asked if this process is covered by TRICARE for Life.
So, and it's not covered by TRICARE for Life, and it's not just TRICARE, but insurance companies do not cover stem cells for orthopedic conditions yet. As far as I've found out, it's not even on their radar yet. They do cover it for leukemia, lymphoma, burns, and wound healing. They do cover physical therapy. People do use, if they have it available, like a health savings account or flexible spending account. But there's a lot of politics involved because this avoids the need for a lot of big, very expensive surgeries that hospitals need to keep their lights on. So there's a lot of politics. But if you look at places like, I was just back at Mayo Clinic last month, Mayo Clinic, Cleveland Clinic, Johns Hopkins, Harvard, Stanford, Kirkland, Job, Stedman, all the major orthopedic centers in the country are doing stem cells because they work. So.
Someone asked if you offer any additional treatments if the initial treatment is not successful.
Sometimes what we'll do, and it's in about 10% of patients, we'll put some more platelets in around 3 months. And it's kind of like a booster. It's kind of like putting more fertilizer on the seeds. And then sometimes we'll also do something called viscoelastic supplementation, which is hyaluronic acid gel. It's kind of basically like putting Pennzoil 10W30 weight into a joint. It just lubricates the joint. So, but yeah, I mean, if somebody comes and at 3 months, they say, yeah, I'm definitely better, but I'm not at that 75, 80%, then a lot of times we'll do what's called a PRP booster, which takes about 15 minutes and just involves a blood draw.
Someone asked for an outline of the cost for like knees and shoulders.
So, knees, we're looking at somewhere around $8,000 for a large joint. And then if there's more than one joint involved, there's a savings, quite a significant savings if you do more than one joint, because the kits, the surgical kits, the sterile kits that are fully coated with heparin and everything, those are the really expensive parts of the procedure.
Someone said they were worried about harvesting bone marrow as they have low bone density and osteoarthritis. They're worried about fracturing the iliac crest.
It actually makes it quite a bit easier to do for me. But no, I use a Jamshidi needle, so I'm going in very gently into the bone. There are some people who use electric drills. There are some people who use hammers. I don't do either of those, and we've never experienced any type of complications from the bone marrow. I teach them, so not an issue.
Someone said they're scheduled for their right hip. The question is that you expect to alleviate all or some of the pain, but does it give you back your range of motion in the hip?
So typically some of that, we do see people improve range of motion. Some of that's going to come with subsequent physical therapy after the procedure. Hard to say exactly how much, but usually we do see people get more range of motion. I have a lot of people who come in. I have a lot of horse people come from Montana, Wyoming, Eastern Washington, and they have a hard time getting on and off the horse because of hip issues. And most of the time, they're able to get back on their horse because we've been able to improve not only the pain but the range of motion.
Someone said that they had a meniscus repair on their left knee and it's now bone to bone on the inside of the knee. They don't want a knee replacement at 69. Are they a good candidate?
Yeah, what we need to do is take a look at the images and do a consult. Bone to bone or bone on bone is one of the most overused phrases, in medical literature. And I would say 90% of the time that patients come to see me and bring their films from the surgeon, and they said, oh, he told me it's bone on bone, I got to have a joint replacement. That we sit down, we look at the films together, and I say, well, look right here. You have joint space. You're not bone on bone. And what I've come to find out from two friends of mine who are on the board of directors at Regents is that in order for a total joint replacement to be covered by insurance, the surgeon has to have the phrase bone on bone in their dictation. So it's very overused. Let me just put it that way.
A couple of people talked about pain and swelling in hands. So they want to talk about if that's worth a visit and kind of what the recovery looks like for that.
Sure, we do. I've actually done my own base of my thumbs, CMC. It's a very common place to get osteoarthritis. We treat hundreds of those. Works very well. The recovery, you basically are doing all your normal activities. The only thing excuse me, I tell people, yeah, we're probably not going to be playing pickleball or tennis for 6 weeks. We're not going to be putting an addition onto the house. I don't want you hammering, screwdriver, and working a jackhammer or whatever. But once again, we're sitting up in that 80% category. I had mine done 9 years ago, and it was just a game changer for me. And then the smaller joints in the hand, sometimes we'll do those just with PRP, with platelets, but also the other joints in the wrist. I actually had couple of patients today with really bad arthritis, widespread throughout their wrists, and they came to me. Their only option from the hand surgeon was to fuse their wrists, which would take away all their motion, and they were not excited about that at all.
Someone said that what kind of scans do you use to diagnose? Do they need to be done ahead of time? Can we do them here?
So first we just get an X-ray and see, what the issue is. And then we might move on to an MRI, or in the case of like a hip or a shoulder, an MRI with dye, which is called an MRI arthrogram. The X-ray, we can do all the imaging here except for MRIs, but we have good connections. We can usually get people in within a couple days to get the MRIs done if need be.
Someone asked if they have two different areas that need treatment. Would you do one at a time or both at once?
Usually do them both at once because even if they're knees or hips or ankles, they don't limit you. You're going to be able to walk. You're going to be able to do your activities of daily living. This way you go through the rehab at the same time. And it also, if you do multiple joints, it does save you quite a bit of money, like $5,000 or so.
Someone said they had a meniscus repair. It helped for a few years, but the pain is back. They have an MRI in a couple of weeks, so they candidate even if the meniscus is fine.
Well, it all depends. It depends what the joint looks like. Meniscus repairs, like we talked about earlier, a lot of people think they had a meniscus repair and they didn't. They just had it cut out. So most likely there's arthritis there where the meniscus was damaged. And there may still be a meniscus tear there, or there could be a recurrent tear in that area. So yeah, definitely it's worth taking a look at and seeing what the joint looks like by seeing those images.
Sorry. Someone asked if they need periodic injections over time.
No, usually it's one and done. Although, I mean, I have some people, I see a lot of ex-NFL and NBA guys who, had the procedure done like 10 years ago. I had a guy come in just last week and he said, it's been great for 10 years. I'm thrilled. And I avoided having a total knee replacement. I still don't want a total knee replacement. He said, can we repeat it? Yeah, it can be repeated if need be. Usually, it all depends where people are in the course of the disease process as to whether or not, a lot of times my thought is we're looking at one and done, unless somebody's got really bad joints. And then, it could be that we do a booster at some point or repeat the procedure at some point in the future.
People asking about insurance coverage, including Medicare.
Yeah, no insurances cover the procedure at this point.
Let's see. Someone said their knee pain goes away after exercise for most of the day, but comes back when resting. The orthopedic surgeon says their kneecaps are too close to the bone. They can't do anything about that. Can stem cell help?
Yeah, that sounds like a case like we talked about earlier. It sounds like chondromalacia, or it could be chondromalacia that's progressed on to osteoarthritis on the backside of the kneecap. And typically, with those people, you get pain when you're sitting, pain when you're going downstairs or upstairs. And they a lot of times they'll feel like crunching or grinding when they flex and extend the knee.
Someone said they have a complete rotator cuff tear, a degenerative labrum tear, and osteoarthritis. Can this help?
Yes, definitely, because your only option is a total shoulder replacement, which isn't a great option. So we do a ton of these because people say, I don't want a total shoulder replacement because it limits you so significantly. Because those stem cells, remember, like that little video showed, they're like little general contractors. They can get, and this is to me the most fascinating joint. When somebody has a rotator cuff tear, a labrum tear, and osteoarthritis, that's 3 different types of tissue. But those stem cells differentiate to each one and can repair. Now, granted, if you have a chronic rotator cuff tear, they're not going to bring the ends back together. But if there's some partial tearing somewhere else, they will heal that and deal with the osteoarthritis and the labrum tear. And then with subsequent physical therapy, we can usually start to see not only diminished pain, which is the number one thing that we see, but then improved range of motion and strength.
Someone said they know a place where they use donated placental stem cells because a person over 60 adult stem cells are not as powerful, viable, adaptable. I didn't think to ask where the donated placenta cells came from or if they were in powder form. Was what I was told true?
Yeah, no. And that's one thing that I have people come in, they say, oh, I saw this doctor who turns out to be a chiropractor, who says, well, no, once you're over, oh, your stem cells aren't going, you've got hardly any and they're not going to work. You need to get placental stem cells. And so basically, yes, you don't have as many as, one of the guys playing in the NFL or NBA who's, 25 years old and 6'4". But you still have a very significant, we're still talking in the billions, which is absolutely plenty to take care of the issue. We have 2 women here that are 103 years old. One came in to have her hips done, and she is so thrilled with her results that she's walking and has no pain and whatever. She brought her 103-year-old friend from her adult care facility in to have her hips done, who's doing well. So, and then, we're maybe getting 1 billion stem cells. So you still have plenty in your bone marrow and in your fat. Don't let anybody tell you otherwise. And you do not want to use placenta. The FDA is trying to get rid of all that in the United States right now.
Some people asked if Medicare will pay for the diagnostic and like the office visit and things like that.
Yes, they cover that.
Someone else said they've been diagnosed with hallux rigidus in their big toe. Can stem cell reverse this?
All depends on what that joint looks like. If there is still some motion in the joint, it can help, but it all depends. What we have to do is take a look at the joint and take a look at the x-ray. So it would be a matter of, even just maybe doing a consultation.
Someone asked if stem cells can be used to treat oh, I can't say this, hernias.
No. Well, let me put it this way. I haven't seen anything yet on treatment of hernias with stem cells.
Someone asked if the quality of the bone marrow depends on age, risk factors, and how do you assure that you have enough?
Oh, we just know, but from multiple studies and from them counting stem cells in different patient populations after bone marrow aspirations and also something called apheresis. So we know because if you didn't have enough, you'd be really sick because you are constantly regenerating tissue in your body. Somebody at MIT did some type of analysis and figured out that if your stem cell production stopped, you would only survive, I can't remember if it was like 20 seconds or 20 minutes. So yeah, you've got stem cells and people have plenty. It's just that you're not as prevalent as they were when you were 15, 20 years old.
Someone asked if you personally perform these procedures.
It is me who does all of them, yes. And I've personally done them on my own thumbs. So, and my own knee. So, yeah, no, I'm very, very familiar with doing. My son has had it done for his knees. He was a NC2A champion swimmer and had knee cartilage issues, and now is doing Ironmans with no problem whatsoever. My daughter's had it done for a rotator cuff. She played volleyball down in Southern California, and she's doing just great. So yes, I have personal experience with it as well as, treating patients with it.
Any opinion about using cold laser therapy as an adjunct to stem cell therapy?
It's okay. I don't know that there's any good robust data out there to say that it really helps, but I don't think it hurts. But I do tell people just because we don't know for sure that to wait like 4 to 6 weeks before doing anything with laser. We don't want to damage those immature stem cells.
Someone asked what the cost of a hip procedure would be. They're signed up for a placenta stem cell injection, but wants to know what the cost here would be.
So yeah, any large joint is 8,000.
And then someone asked how much like the thumbs would cost and would stem cell therapy help carpal tunnel?
No, stem cell therapy not for carpal tunnel, but we do PRP for carpal tunnel. And then the cost for thumbs for small joints is what?
So one thumb is 4350. Two, I want to say, is just under 7,000, I think, or about 6,500. So, and then someone asked if they make an appointment, how long would it be to have the procedure?
Typically, I mean, the nice thing is for this whole office, it's just me here for right now. My son's joining me in a year, but so we get people in, usually within a week or two.
Yeah. If there's any other questions, please feel free to submit. I don't have anything else as of right now, but I will be sending out pricing information as well as this webinar tomorrow.
Which, yeah, everybody should get that on their email. And I'd like to thank also IRG, who I deal with their physical therapy offices all the time. They do a great job. They've got offices all over the Puget Sound, and they have just a great host of physical therapists, and they're kind of doing this webinar with me as well, and they have done numerous ones in the past. So yeah, if you have any questions, call in, email us. We can always get you a consultation and see. And if I don't think you're a good candidate, I'm going to tell you. And maybe you're a surgical candidate instead, in which case I'll refer you to somebody who's good and who I know well in order to proceed on with that. So I'd like to thank everybody. Any more questions at all? No. I'd like to thank everybody for joining in tonight. And once again, like I said, if you need anything, just contact us here at the office. Thank you, Chels.